Good evening, everyone, and welcome to the first webinar of our Better Billing series, the 715 Aboriginal and Torres Strait Islander Health Assessment 29. My name is Helene. I'm the Workforce Development Officer at Westvik PHN, and I will be your facilitator for this evening alongside Jade Buller, who also works in our workforce development team. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country tonight. We recognise their diversity, resilience, and the ongoing place that First Peoples held in our communities. We pay our respects to those elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN YouTube channel. Jade will put the link on that into the chat. Please see our upcoming events on the screen now. You can register for these events via our website, and the link will be also in the chat for you to get. A special mention to our upcoming education dinners for GPs and practice managers in Warrnambool, Ocean Grove and Hamilton. Enjoy complimentary canapes and sit-down meal with colleagues. Register link is in the chat. Please make note that of the Westvik PHN health pathways relating to this topic that is on the screen at the moment. Most of you are familiar with our health pathways. It's a free online resource and localised clinical and referral information for health practitioners. You'll see on the slide here some of the related pathways available. Westvik PHN will provide a certificate for your attendance. Please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, just rename yourself or type your first and last name into the chat. This will help us ensure that you get your certificate of attendance. The event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question time at the end of the formal presentation. We encourage interactivity and discussions. Please feel free to type questions in the chat box at any time, and I will ask them on your behalf to the presenter at the end. Your feedback is important, so please take the time to complete the event survey after the webinar. There will be a link in the chat box to complete the survey. Our presenter for this evening is Ash van Leeuwestyn from Better Billing. So welcome, Ash, and I shall now hand over to yourself.
Thank you, Helene. I'm Ash, everyone. Let me just pop through. Can I make sure everyone can see the screen? Helene, do you want to let me know that that's all good?
Yes, we can see it.
Perfect. Okay. So I'm Ash van Leeuwestyn. I'm a GP registrar. I've just passed my exam, so hopefully not for much longer. And I own a company called Better Billing. So Better Billing is an online-based platform and course that I've developed over time in general practice, learning and dedicating a lot of my time to the MBS and learning it and trying to apply it in practice. Prior to doing general practice and as an intern or resident and during my med school years, I owned a number of businesses, one particular that I sold towards the end, got quite interested in the business side of general practice, and it was one of the reasons why I decided to come into this specialty after I finished my my training. In terms of what we're going to be focusing on today is the 715 health assessment in general practice. So I am speaking to you guys from the New South Wales Central Coast, or Darkinjung land, which is where I live and work. And hopefully tonight you guys will be able to take something away for your own practice. Things that I might discuss or ideas I might discuss tonight might just not be relevant for you, and there might be some things that you take away that work really well, and that's what I hope. I'm the first person to say if I have found anything that is incorrect or I've mentioned something incorrectly, I'm absolutely happy to discuss it, and will always check my answers rather than going straight ahead and just blatantly agreeing. So please bear with me as we get through this anyway. So the topics tonight, so I'm doing a 3-part series, and this is the first one, which is the 715 Aboriginal and Torres Strait Islander Health Assessment. And obviously we've done an acknowledgement country thanks to Helene, but obviously respecting our traditional lands of all the Aboriginal people and our roles that we play in their health, keeping them healthy and getting healthy together. So an acknowledgement of that for myself. So what is Better Billing? So Better Billing, like I mentioned before, is an online-based MBS education program that I created. So we do 3 particular things. We have the online courses, which is done as an online platform. You can use it through an app or through our own web page as well, or iPad, whatever works for you. We also do a lot of templates, which are sort of being phased out as we're starting to see AI happen a little bit more. But there is well over 120 different templates that have been created by myself for common situations and common presentations, which you are very welcome to use yourself and add into your autofills. And then also coaching. So in some particular GPs, I've got a fair few following that have regular monthly coaching with myself, group coaching in practices as well. So if you want to have a look at that afterwards or have a chat with me afterwards, you're very welcome to find me there through the online way. So yeah, your health is in your hands, and the 715 check is really important. I've been researching for one of the other talks that we've got, which is called Small and Mighty, which are the missed MBS items, and specifically having a look at the MBS items for all of Australia and seeing what are the most popular ones. Obviously, you've got your general attendances, which are most popular. But one thing that I found specifically for Victoria is it's the lowest in use of the 715 check. And substantially quite low, so even so that it actually appears in my lost item numbers chat, which is coming up in the next few weeks. So have a bit of a reflection, take this as a bit of time of reflection. When is the last 715 that you have done? When's the last time you asked a patient, are they Aboriginal or Torres Strait Islander? And asking them more than once, quite often you will find that they will start to become more comfortable and then will tell you, oh yes, that is actually the case. Some may just come out straight away with it, which is all great. However, the 715 is really quite often, I find, GP directed. Patients normally don't know about it. I feel like in my practice that's the case, and getting them on board with it is really important, having that every 9 months as well. So why would we do a 715? What's the point? And what's in it for the patients? What's in it for yourself? So obviously, it's a really good way to keep patients engaged in their health and their healthcare. Access is another option for a bulk billed item number, which, I mean, GPs are constantly under the pump about being bulk billed and why or why not I am not. And it's another way that you can see your patient and being able to bulk bill them for that attendance. It's also a really well paid item number. Like it is quite decent in terms of what Medicare offers us. It gives obviously the 10 access to the allied health services, which is another lot of great services that patients just do not know about until they have a 715, or just they might not even know that they need it at the time. And there's no minimum time requirement. So an MBS item without minimum time requirement is just gold. It's really quite good. It's not like one of those health assessments where you have 20 minutes as a requirement or anything like that. It's not got a time requirement. That does not mean that I'm encouraging anyone to do this over 2 to 3 minutes, because that's not a really well done one, and that's wasteful for yourself and it's wasteful for the patient. And in the circumstances of an audit, having a 715 done in 2 to 3 minutes and one thing typed on the template, you're going to get pinged essentially. So use it wisely, but it's also helpful in the way that you need to structure your consults. You don't need to stress too much about what time it is. So down to what does Medicare say that I have to do for my health assessments? So who is this for? So this is for all Aboriginal and Torres Strait Islander patients every 9 months. So this is not a yearly, this is not 2 yearly, nothing like that. This is a 9 monthly one, which is the quickest health assessment that we have. This is for patients who are not in hospital. and they're not at an RACF or a residential aged care facility, obviously it needs to be claimed by their regular GP. And quite often Medicare Online has given advice previously that GPs can be given explicit permission by a patient to do one as long as they refer that on to their regular GP. Not sure how happy the regular GP would be if they were already keeping this under wraps for them. But being, hoping that most of us are really seeing the same regular patients, you're able to claim this as their regular GP. A lot of the legwork can also be done by your practice nurse or an Aboriginal and Torres Strait Islander healthcare worker. And I'll show you different ways of how I sort of structure this as we get on, using a nurse. And then for those of you who just don't have access to nursing staff at the moment, which is a possibility, how you can do it that way. So what does it actually include? So you need to have consent. So talking about consent and having the actual health assessment, patient history and undertaking examinations and investigation, overall assessment or an impression of the patient, recommending your interventions and advice, and offering them a template of the health assessment as well. Sorry. So having a look at this, what you can sort of see in terms of the health assessment that's conducted, sorry, just one moment. Okay, sorry. So once you've actually completed the 715, quite commonly the most common things that people have no idea about is the 10987, which is the follow-up number that you're able to do as a practitioner. And that is available 10 times per year. It's a really common combination billing tip that people just seem to not be able to actually know about. And it's something we'll talk about doing as I go on. So frequently asked questions about the 715. So how long do I need to spend? So there's no minimum and there's no maximum time. Does a nurse or an Aboriginal healthcare worker need to be involved? So no, they don't. They don't have to. You can do this yourself. Another common question that I get asked is about the minimum age that these take to start. So quite often I will start this from the 6-week check, and that's absolutely fine. You can also do this every 9 months. And a patient themselves, how do they prove that they're Aboriginal or Torres Strait Islander? So there's no need for this. In healthcare, if someone identifies themselves as Aboriginal or Torres Strait Islander, or both, that's enough to commence the 715 and add them to close the gap. So there's no evidence needed. You don't need to, no need to make the patient also feel quite uncomfortable in that way by asking to prove their Aboriginality or Torres Strait Islander heritage. Sorry. So how do I also add a patient to the Close the Gap scheme? So that's also done through PROTA. A lot of our nursing staff are able to sort of help us with that quite often. But that's one big component of the health assessment to be able to do at the start is asking them, are they on the Close the Gap scheme? Are they aware of what it does? Are they aware of the regular changes to medication prices when they're on it? Another thing is, can the patient access other health assessments? So there's nothing really specifically written in the MBS about this. However, your 715 is taking precedence over the other health assessments, which we'll get to in a second. Quite often, people will also ask me about whether they can access a care plan and a TCA once a 715 has been done. And you absolutely can, which again, I will show you different ways that that's about. You can also do it on the exact same day, which is a common question I get asked, but it's absolutely fine to be able to do that. So the templates. So there's a few different ways that you can think about using the templates and what ones you do. I really recommend that you explore all the different types of templates that are out there and decide what one works really well for you yourself and your practice. So there's a few different ones I personally recommend. So the ones by the RACGP are top notch. There's really not much better ones than those. They've been really well created and in combination with NASHO. And they're really quite age specific, and I think they do a really good job of requiring what we need. In a time of AI and Lyrebird, which or Heidi Health or whatever ones are you kind of using, there is a need for accessing those templates as well through that system. I personally use Lyrebird, and on the community page of Lyrebird, I've created some Aboriginal and health assessment templates, which you can access through the community in Lyrebird. So if you have a subscription, you can see those ones in there, and that way you can kind of talk the health assessment through without having to worry about going through each of the templates themselves. If there's other options, or you have your own template and you're willing to chat about it or share it amongst colleagues, I really recommend that you do. Whatever one that you want to choose, I really just recommend that you stick with it and make that consistent for yourself. So what are the differences in what Medicare wants in the templates? So there's a few different things that are the differences between Medicare's templates. I'm not going to go through them excessively, but this is a good table that explains to you what should be happening in someone who's under 15, someone who is between the ages of 15 and 55, and the ages of 55 and older. So in these particular cases, you can sort of see here that we've stopped, we're not too concerned about birth history over 55 years of age. We're wanting to talk more about social function and falls over 55. These are all just common, normal, expected general practice management and investigation. And so have a look at the differences there. If you decide I actually want to go and create my own template, then you're very welcome to. I would have a good look at that yourself and decide, okay, what do I need? And these are the requirements as per Medicare. So when it comes from the MBS, what they recommend and what's on the RACGP templates are not exactly the same. There are more on the RACGP templates, which is good. But however, if you wanted to change it up yourself, this is what you would be needing to find. So how do you get patients interested in the 715? How do you get patients who you can look for Aboriginal or Torres Strait Islander patients? What are the ways that you can do it? There's a whole host of ways that I've seen clients or our own practices be able to do. I really recommend that you sort of sit down with your own practice, your practice managers, your other doctors, and ask what other ways can we increase the 715 numbers? So asking your patient if they are Aboriginal or Torres Strait Islander is probably the biggest way to increase your 715 numbers or the access to them. If there's other, please pop in the chat if you've had any really good success with anything else, or other sort of artwork or in being involved in social events, etc. Okay, so this is the most commonly asked thing that I quite often am asked about, which is the 715s, co-claiming, splitting time. What can I do? What can I can't I do? So flatly co-claiming and splitting. So this is a really common thing that I feel people get confused between the two, and they think they're the same. So co-claiming is something that you don't need to worry about time related. And splitting the time is about time spent on each item. So having a look at what you can co-claim flatly, so having a look at the care plan and your TCA, they are item numbers that you can co-claim completely. So if you spend the time with the patient, or the nurses spend a time with the patient doing the 715 and a care plan and a TCA, they can all be claimed on the exact same day. There is no need to discuss about time or entering in time to Medicare as to how much time you spent on each of them, because they're both not time related, the Medicare item numbers. ECGs, spirometries, or pregnancy tests can also be done and co-claimed on the day. An ABI, if you have an ABI machine, so it's not one, it is normally more expensive to have one of the ABI machines, but unfortunately, However, if your practice has invested in one, that's a really good option too. And obviously the bulk billing incentive will be flatly co-claimed too. Splitting the time of the consult is normally about the other item number. So like I mentioned before, the 715, it's not a time-related health assessment. So if you were going to do a mental health care plan, so they're going to be time related. If you had any discussions with a COVID vaccination and that item number 93644 and discussing how long you spent on that, that is something that will need to be split. Quite often people will process the two together, and it's a very common exception that returns from Medicare, is that need to have, even if it's a 2-minute discussion for the COVID vaccinations, adding 2 minutes next to the split of the time when you're sending it off to Medicare. Other health assessments as well, so they're time-based. So say, for instance, your 705 or your 699, these are all time-based. So that's one thing you're going to have to get reception or yourself to particularly process, is making sure that Medicare sees that these were two different consults that occurred in the same time. In terms of other health assessments and the heart health assessment and doing those at the same time, I say this with caution. It definitely can be processed through Medicare and it will go through. However, it needs to be you need to think about, how can I possibly explain how it's relevant to have both a heart health assessment and a over 70, over 55's 715 health assessment done. Is there another reason? Was the Aboriginal and Torres Strait Islander health assessment focused purely on social and mental health, and then you accessed a heart health assessment elsewhere, or a vice versa with say a 705 if they were over 75? What did you spend on that time? So be really clear about the clinical need to do both of those. Okay. Another thing that's I always mention is, obviously you can't claim a 23 or a 36 or a 44 in a non-emergency situation. So Medicare's got it really clear on the explanatory notes for 715. It will say you cannot, we don't encourage you to claim an attendance item in a non-emergency situation. Obviously things change, people might come back and then all of a sudden have crushing chest pain, and you've already billed the 715, you need to see them, or there might be some sort of acute issue. But however, you cannot split or you cannot co-claim a 715 with a 23 or a 36. It's not, Medicare will instantly decline it. So I have 3 different focuses of patients. These are all fake patients, or patients that I've kind of thought of, oh, I've seen somebody like this with some of the scenarios, and hopefully you'll see some of them and for yourself be able to see, oh, this is a patient who I also have too. And the biggest thing, again, which has been mentioned, is asking the patient, do they identify as Aboriginal or Torres Strait Islander? And normally more than once. I really recommend doing it. So this is the first fake patient that I've got, who is Mia, and is a 25-year-old female who presents as a new patient who's new to the area. She identifies herself as Aboriginal and just wants to get her pill script repeats, please, and that's what she's here for. After having a bit of a chat with her and getting history and just sort of filling out her profile, she's a smoker, she's a non-drinker, her BMI is quite high, she's 38, she's non-intensive today, she lives with her partner who she's moved here to be with. She's doing uni online, doing psychology. Her family live 3 hours away on country for her, so she's away from home. She's never heard of a 715 or a health assessment before in her life, despite being 25. And she said her family history, they've got lots of type 2 diabetes for both of her parents, and 3 out of her 4 grandparents have type 2 diabetes. There's also some addiction issues going on for one of her siblings, and schizophrenia in a maternal uncle. So quite often, how would I process this and how would I see this patient? Obviously, there's the medical component of it, and seeing her and talking to her about the pill, and is it even relevant for her? Is that in her best interest, or should we talk about other contraception? But it's also about planning her timeline. And for me, that's how I sort of think about both sort of sides of the consult. So having a look is what I do, is the timeline. So I see here that I see her for the first time, and everyone sort of says, oh, you can't do a 715 for the first time. And I think that's quite fair. You might just be becoming the patient's regular GP. And I think if that's really clearly documented and saying, I'm now taking over care, I think that's fair. But for myself, it's too rushed, and I like to have it planned out. So for the first one, I'm going to be seeing her and talking about her history from her file, planning the idea of the 715. Like she said, she's never had any health assessment done before. So I think, okay, bloods and urine as per the investigation table that was from Medicare and in the template. And then obviously because of herself, her history, organise other contraception and talking about other contraception. So in this particular case, I've spoken to her for, say, 15 minutes, and I've gone with a private 23. And in this case, it says a $90 charge. Then in 93644, so in this case, we've decided to talk to her about what were her COVID vaccinations, where is she up to, would she like another one, would she like us to do it here? She's not interested, or she's interested, and move on from that. So we decide that with her other contraceptions, we've gone with Implanon. So that's going to be something that we need to organise down the road. So we're planning on her next appointment. Normally what I'd like to think is I will get my staff at the front to book in that next appointment, and I'll mention what it's for. So in appointment 2, in my ideal world, I have our nursing staff conduct the 715 and observations for them. And then what I will do is spend that appointment running through the results of her bloods, her urine, etc. And run through the remainder of the 715, giving the interventions and providing my impression, which is one of the biggest and most missed things on the 715 templates. So that then I'm able to build that 715 number as well as the bulk bill incentive, because it's a bulk billed item. Then I think about, okay, the Implanon procedure is coming up. So I see her at appointment 3 for the planned Implanon procedure. Now we've organised this to be a part of her her goals in her 715 assessment. Is weight loss was one, and the other one is about changing contraception and Implanon. So in this particular case, I've gone and inserted the Implanon for her, but also I have also seen her for an ERTI that day. So she said, oh, I'm unwell, etc. So we're going through that process, and that's where the 23 bulk bills come from, because I'm privately billing the Implanon and keeping the 23 as a bulk bill item for the ERTI. Then the 10987, and this is so underutilized. I think a lot of GPs don't even know it exists. A lot of people have heard of the 10997 because of the nudge letters and the news around that from Medicare point of view. But in this particular case, it's really quite important for follow-up and relation of goals and education. So with a 10987, what can you actually use it for? So you'll see a few different in my examples here, but in this case, it's about repeating her observations. So we're wanting to do a weight check and see how that's going. Assistance of the nurse with helping me with getting the goal of the Implanons, getting her covered with contraception in another safer manner. Then that's completed in that appointment, and you can see those codes there of what has been billed. Then in appointment 4, we're talking about the Implanon, so I might do a 6-week check and see how's it going, how's he bleeding, etc. And also in her case, we're going to be talking about weight management, and again, the observations are completed again. The nursing staff are seeing her, reviewing her, and seeing what she looks, how she's going with her lifestyle interventions, all in relation to that 715 goal. And that is, I feel like that is how I like to sort of get the pathway of most of my patients who are for a 715. In this case, would this lady be available to have a GPMP and a TCA? No, there's no chronic disease unless all of a sudden her bloods came along and she's diabetic, or she has macroalbuminuria, or whatever it might be. That's different, but in this case, it's not. But we'll look at something next which shows you a little bit differently. So this is another patient which we've got here, and that's Michael, who's a 51-year-old man, and he identifies himself as Aboriginal. And he's a long-term patient of the practice, but his current GP's just retired. And like all good GP registrars who come in, they seem to take over the retired GP's patients. He's unsure about the last bloods, but has come in for a checkup. In this particular case, let's say that the patient is from another practice and we don't have any of this information. So having a look here, this is a bit more of a complex patient. So he's a non-smoker. He drinks 2 standards per week, only on a Sunday afternoon. BMI is 29. He's got a decent personal medical history. So unlike me, he's got a fair bit of chronic disease going on. Lives with his wife and son. He works as a registered nurse. Younger brother had an NSTEMI 2 months ago, and that's why he's kind of coming, because he thought, what if this happens to me? And both parents for him have passed away at a young age, from another NSTEMI for his dad and from mum from breast cancer. So how would a big, huge patient change of having to bring Michael over and manage all of his issues, how would I put his timeline? So I would put it a bit like this. So quite similar planning again for the 715 in that first proper meeting of Michael. So again, it's quite hard to do that unless you had, 30, 40-minute appointments and you felt comfortable doing it, by all means. But in this case, normally what I would do is I would say, look, this is what I want to do for you, Michael. We need to do bloods and urine. This is why. I also think, you're going to really benefit from a whole host of allied health in this particular case. So whatever that might be. So for him, it might be a diabetes educator, it might be exercise physiologist, podiatrist, whatever it might be. So I explained to him as well that in the next appointment, we're going to do a bit of an assessment as well as a care plan, which helps organize those allied health sessions. So I feel discussing this with your patient rather than not discussing it and sort of just letting them reattend for a follow-up appointment, it helps prevent them from not coming. So quite often they will say, I know why I'm here because I'm doing the next steps of trying to get myself better, or we're trying to lose weight, or whatever it might be. So involving them in saying, how does that sound to you? It's one, empowers them to feel like they're making their decisions in their health, which they are, but also I find that quite often, not never, but quite often, my do not attend rate is quite low if I'm getting them involved with that. So then having a look at appointment 2, and I have got my nursing staff amazingly to do the 715, the OBS, and he also needs an ECG because I've decided even though he doesn't have any chest pain, I just want a baseline one of that at this stage. And then I'd run through the 715 with him and the results. At this point, I'd also get our nursing staff to create the care plan and bill this on the same day, so that all of his allied health visits are going to be created for him on the same day. So obviously between the care plan and the 5 and the 10 that he can gain through the 715, that's a decent amount. And having them sent off to everybody with my nursing staff's help would be great. If I didn't have nursing staff, doing a 715 and a care plan myself, even though I have a lot of automations in my workplace and having those things sorted, it would be really quite hard to do that properly. So feel free to split it out. Michael is not someone, hopefully, who is only coming every 2 years. He should hopefully be coming a little bit more, and use that way to be able to sort of plan your own timeline that way. So the billing from this particular appointment, you've got the 715 and the bulk billing incentive, your ECG code. You've also got your 721 and your 723, because in an ideal world, your team care providers are next door and they've all said, yes, happy to go ahead. Obviously, you'd be holding your 723 if that wasn't the case. Then with his depression history, in appointment 3, Michael comes in and discusses he wants to get a mental health care plan. It's time for him to go back and start doing some counselling or work on himself. His brother's death is starting to really, get him down a little bit more. So all of a sudden we're here at appointment 3, and it's actually time for us to review his care plan because we haven't actually seen him for, say, 3.5, 4 months. And so we use the time to create a mental health care plan, which is, in this case, is the 2715. So we spent 20 minutes. And at this point, I also will get him to be seeing my nursing staff for his observations and discussing anything from the 715 about what we were going to make as his goals or his education to follow that up. As well as that, I'll do a 732 and 732 myself. So reviewing the care plan. How did he go with the podiatrist? How's he going with the exercise physiologist? The care plans, I will be doing a talk on at number 3. So you're welcome to come along and see that too. I won't go deeply into that today. So as a result, you've got quite a decent amount of codes that you're billing in this one appointment. The 2715, the 10987, the 732 and the 732, and all of the bulk billing incentive numbers in there. If you're a practice who privately charges for your mental health care plans, you can do so with the 2715. I don't, which is why there's a bulk billing incentive code in that one there. Then you see him at appointment 4, and say it's only been 2 months since then. And so as a result, you get him to see your nursing staff beforehand, and they're on a good ABI drive, like a lot of our nurses are at the moment. And we see that we're going to get them to do an ABI while he's here, and they'll do their OBS as well as an ABI and review how he's going with his 715 goals. So as a result, he also ends up coming and see me for prescription renewal and a general check on how everything's going. And we end up with those codes there. So the 23 private in this case, a 10987 from seeing the nursing staff reviewing how his 715 is going, the ABI code, and the ABI is being bulk billed in this particular case. And so we've got a bulk bill incentive going on too. Now, the 10987 is a really interesting number. And I think if anything that you get from this is go and have a look at it on MBS Online today or tonight or tomorrow, whenever you want to see, and just think about it. It's about $27 to $30 as a rebate. It's also something that your nursing staff can do without you having to consult with the patient. So say, for instance, I have a patient who's a really bad diabetic, had their 715, and they see the nurse every 6 weeks to have their weight checked. Now, there's not always appointments with me on the same day that's happening or the same time that's happening. And so as a result, a 10987 can be billed solely without me having to see them. If I see them for something else, then a 23, etc., will also come along with it. But in this particular case, that's what's happened. But if your nursing staff is seeing the patient independently without you having to see them on the same day, a 10987 is the only item number that's going to allow that. So if anything, go and have a good look at that one today. It is in my missed item numbers because it's a very, very missed item number for Victoria. So we will be touching base on that as well if you have more questions or you think of something next time. So then they say, Ash, I don't have the nursing staff to get this done. That's absolutely impossible for us. We've got one nurse and she's booked out 6 weeks ahead, and we've got her doing health assessments all day long, and I couldn't get her to do a single OBS if I really had to. And that is the case with a lot of practices, and I totally respect that. So how would you do this if it was just you sitting in your chair doing it yourself? And sometimes that happens. We've got nursing staff on holidays, etc. And so how would I have done this? So the last one, this is one of the last examples and slides that I have got here. And this is Nari, who's an 85-year-old Aboriginal woman. She's moved locally to be with family. And she said she's not seen a doctor in over 15 years, which she thinks is amazing, because she was a carer for her husband who has since passed away. Now, in this particular case, she's a non-drinker and non-smoker, and she lives with her daughter. She's got 2 grandchildren who also live in the house and 4 great-grandchildren who also live in the house with her. The last time she had blood work, it was in her 70s, and she doesn't remember ever having to talk about the bloods with anybody, so she assumed they were all good. She's come to me because her daughter said, you need to go get your lightheadedness sorted out. We don't need it sorted. We don't know what's going on. She also says, I've got some issues with my bladder that I'd really love to get rid of too. And she's got a really decent family history herself of type 2 diabetes, CKD, STEMIs, and an early death with MIs in her family history here. So being say a solo GP or a GP with a part-time nurse, etc., how would you process and do a 715 if you don't have the time to do all of that, which is absolutely fair. So like I said, you're meeting Nari for the first time, and that might be a private 23, etc. But in her case, her lightheadedness, I've decided I want an ECG done today. So as a result, I've also billed for that number as well. Now, quite often, I have done this, and it's worked really quite well. If you want to print out the 715 template, it's a bit annoying because it's paper, and I mean, not all of us love paper, and that's okay. But you can give your patient the 715 template to take home to fill in before the appointment. The left-hand side of that template is really quite easy. You know, is there any concerns with your hearing? Is there any issues with have you had falls? Are you incontinent? And a lot of that they can sort of go through themselves, and then they can bring it with you, bring it with you the next time they see you, and go through that process. So that is a really good option. It's just a printout. You just take it to them. If you had your own, you're very welcome to do the same. But that way they feel quite important. They've got their little homework and they're going to bring it back to you. So then at appointment 2, you actually do the 715 and you run through what they've said in it and their goals. And it's also a way to get a really good set of goals, because the patient sat there with the template themselves and said, what is really important to me? And while Nari might have lightheadedness, which is a bit of a concern, and we're not sure what's going on here, she's more worried that she's still leaking urine and she really doesn't like it. And that's her priority. So a good way to let them reflect and you be able to see what's truly coming through. In this particular case, I'd also be thinking about getting a care plan created. Now, if you're on your own, like I said to you, doing a 715 and a 721 and a 723 on the same day is pretty tough. And so as a result, I'm sort of setting up that pathway and running through that 715 in that appointment and the results and saying, I want you to come back the next time, because next time when I see you in a week, 2 weeks, etc., I want to see how, 1, reducing that caffeine on your bladder has gone. I want to see how, you know, your bladder diary, I want to see extra, et cetera, et cetera. So then explain to them that when we have a look at that, we'll talk about getting you in with a pelvic physiotherapist, whether that's relevant for Nari or not, and do that through adding and accessing a care plan. So you can see in appointment 3, that's what I've done. So accessing the care plan in appointment 3, focusing on the leakage issue and for a pelvic physiotherapist to be involved. Then say an appointment 4 for her, she's come in and she said, oh, I need all my scripts, and it's an opportunity for a review. She hasn't been booked in for a review. There's nothing like that happening, but you take the opportunity and you complete it there. Okay, so your 732 and 732 is done. You somehow sneak a nursing observation in. Now that's a bit cheeky, obviously, because if your nursing staff's not involved in a 10987, then it's no dice. So this is an item number purely made for nursing staff and Aboriginal and Torres Strait Islander health workers only. So if they're not involved, then you can't claim this number. And then I also decide that she's also somebody who could also have an ABI done. There's NSTEMIs going on in the family. She's also got a plethora of health histories, which I've obviously found by being thoroughly looking into her. So this is one way that I would be able to do it if I didn't have a nurse. Now, what you would have seen in a lot of the examples is in this particular incident is that Nari in this case has only paid 1 private fee, and one in these particular patients, sometimes financially it's quite hard for them to come and see you. And I really encourage you to sort of mention to them that you're accessing chronic disease item numbers through Medicare. And when you do that, it's because you're able to financially, and they're able to see you bulk billed, and that as well really reduces your do not attend rate substantially. If I tell them that this is what's going on and that appointment will be bulk billed, they think it's like a free price, which it is because they're getting more and more out of their health. Okay. So that is the 715 for myself. So Helene, I thought we could run through some of the questions. I apologize, I had like a coughing fit there at like 10 minutes in. But if anyone has any specific questions about the 715, and yeah, if not, I am doing the small mighty one in is the next one, and then the care plans is the final one, which we were going to wait for the changes that are no longer coming, so we're going to do the old school care plan one.
Okay, thank you. I do have a couple of questions. Can you do a 699 in this instance because of his family history?
Yeah, so I'm going to assume that was for Michael. And yeah, so this is absolutely, so yes, you can because you've got clinical reason. So say, for instance, if you're in your 715, you've decided to focus on Michael's depression, or you've spent a lot of time on Michael's preventative health. He's talking about his obesity. He's talking about how he doesn't want to have an NSTEMI himself. Sure, but if you are making that really clear that that's not focusing on your heart health, then and you do a 699, then you absolutely can. Yeah.
Thank you. How often can you claim a heart health check?
The heart health check, the 699.
Yep.
So so that one I will triple check for you, but I believe it's only every 2 years. A 699 is, I kind of call it the consolation prize of health assessments. It's sort of a it's I don't know why they gave it to us. It's a bit helpful sometimes, but rarely good to be done on its own. Again, it is something that will actually come up in my next one as a missed item number that people don't tend to do because they don't know really how to use it. I predominantly only use it with care plans when I'm getting care plans done. But yes, you can. I will triple check that for you. But my understanding.
Yeah. And just a comment, I thought you couldn't claim HHC-699 within 9 months of doing a 715.
Yeah, so this is a really common question and it's always up for debate. So a 715 and a 699, the two, so 715 is the only health assessment. I call it the unicorn because it allows so many extra things to happen. If you were talking about a 705, if you were talking about a 701 or any of the other health assessments, it's a no. So hence why I call the 699 a consolation prize. So in this particular case, you can. Do I often do it? No, because I do tend to focus a lot more on the heart health stuff within the 715. But it is absolutely, I have seen it absolutely go through from Medicare and have seen Medicare online as well in emails, etc., say that yes, this is the case. It is fine to do it. However, if you were getting it declined from Medicare, you need to put in the explanatory notes that this is clinically relevant, or and reattempt to reprocess that if that's what's coming back and saying that an item number has been claimed within the time limit of the 9 months of 715.
Now I've got another one here. In our clinic, most of the ATSI patient gets, I think that's bulk bill
Yep.
in. Can I bulk bill 23-10990?
Is that one written in the chat, Helene?
Yeah, it is. You can read it. It's the bottom one.
Mm-hmm. That's okay. I can't see. So yeah, if you're bulk billing, if it's a question about bulk billing a 23 with a 715, it's a no. So that's not the case. But if you were just seeing someone and it was bulk billed and you're bulk billing their 23, then absolutely. And 715 it is a bulk billed item number as well. So the 715 and the 23s do not go together. Okay, so that's something that cannot be claimed unless there is an emergency. And an emergency is something that is acute and cannot be left within 24 hours. And if you can claim that within your documentation as to why this is acute and cannot be left, then you can. However, I would proceed so with caution is my recommendation.
Thank you. I don't have any other questions. We do have a little bit of time. So if you have any, quickly type them in the chat box and we can get Ash to answer those for you. We've just got the link in for our evaluation survey. If you could take the time to complete that, that would be very good. Yep, there it is up on the screen. So if we don't have any more questions, I will finish the session and thank Ash very much for today's presentation. Very informative, really good information, very clear understanding of all that. So we're very fortunate to have you. Thank you so much.
Thank you. And yeah, if anyone has any other questions, they're very welcome to go directly to my website and put in a contact form. That way I'm happy to just email you directly across and say that you have seen my presentation and want to chat more. Otherwise, hopefully, thank you very much, everyone. Sorry for coughing. Oh my goodness, I couldn't believe it.
No, thank you. And there's some great comments coming in. Excellent presentation. Thank you. That was great. All that sort of stuff. So we'll send you all the details on that, Ashley.
No problem. And if not, I will see you guys at the next two.
Yeah, definitely. Thank you.